Stop prescribing Medrol, Dosepaks, or Prednisone for community-acquired pneumonia or other illnesses that are transmitted in the wintertime. This should not be the thing that goes home from an urgent care visit. I know you just want to give your patients something when they come in with a cough or a cold or whatever. Stop giving them Medrol. They don't need it. It doesn't work. Why would I say this? Well, remember the antibiotic stewardship programs when they would say, okay, guess what? Antibiotics do not work to help with viruses. But guess what? Medrol doesn't help with viruses either. It does not work. Stop prescribing it, please. Urgent care doctors, primary care doctors, anybody who's seeing people with your typical winter things, flu, cold, COVID, pneumonia. This does not help. And it can hurt. So I want to go through the specific guidelines, if there are any, for these conditions, and the specific text that comes in Up to Date. Up to Date is the most well-respected medical reference, and it's written by experts at each topic, and it includes evidence-based information. And so I'm going to quote them directly so that you'll believe me. But at the end, I will share with you the very small exception of who can actually benefit from a Medrol dose pack. All right? So here are the conditions that it doesn't help with. It does not help with influenza, community-acquired pneumonia, bronchitis, cough, COVID, sinusitis, otitis media. None of those it helps with, all right? I'm going to read the quotes directly from them. So influenza. In a meta-analysis of observational studies, glucocorticoid use was associated with an increased mortality risk. You're killing people. Like I'm losing my voice because I currently am dealing with one of these infectious diseases. This is killing people who have influenza, okay? It's associated with an increased mortality risk, odds ratio of 3.9, with a confidence interval of 2.31 to 6.6. Given the possibility of harm, glucocorticoids should not be used as adjunctive therapy for the treatment of patients with influenza in the absence of a separate indication for their use. There's a clue of what we might be talking to at the end of what it actually is beneficial for. The IDSA, the people who create the guidelines for infectious disease, they said, clinicians should not administer corticosteroid adjunctive therapy for the treatment of adults or children with suspected or confirmed seasonal influenza, influenza-associated pneumonia, respiratory failure, or ARDS, unless clinically indicated for other reasons. Do not give them this for pneumonia. Do not give them this for influenza. Do not give them this for respiratory failure. It doesn't help. Community-acquired pneumonia says on Up to Date, limited role for glucocorticoids. We do not use glucocorticoids for the treatment of community-acquired pneumonia in the outpatient setting because the potential harms likely outweigh any potential benefit. The benefit to risk ratio for glucocorticoid use appears to be the greatest in critically ill patients with community-acquired pneumonia, and we do not use glucocorticoids for selected critically ill patients. Only selected critically ill patients. That means these people are in the hospital. There is no reason for an oral pack going home with someone who's not critically ill, hospitalized. They're probably using injectable anyway. This is not necessary for a community-acquired pneumonia, period. Because most critically ill people can't swallow, all right? Like, not necessary for pneumonia. No more Medrol pack plus Z pack for pneumonia. Not helpful. Okay, COVID. So COVID is another one. Systemic glucocorticoid. We're going to skip COVID for now. Bronchitis and cough. We suggest not using ibuprofen, oral corticosteroids, or herbal remedies for cough related to acute bronchitis, either due to lack of efficacy or safety concerns. Both ibuprofen and oral corticosteroids were not shown to be more effective than placebo for reducing the severity or duration of cough in randomized trials. This doesn't help with duration. So people will keep coughing even if they take this. It does not help with severity. They will keep coughing hard even without this. This is not helping with bronchitis. This is not helping with cough. COVID. Systemic glucocorticoids in outpatients. In non-hospitalized patients, we do not treat COVID-19 with dexamethasone, prednisone, or other corticosteroids. There is no evidence that corticosteroids benefit patients without a supplemental oxygen requirement. And further, they may be associated with poor clinical outcomes. Do not give this for COVID. Okay, say they got the flu and it became a sinus infection. Is it now indicated? Well, it says under sinusitis, systemic glucocorticoids not indicated. We suggest not using systemic glucocorticoids in the treatment of acute bacterial rhinosinusitis. When given in addition to antibiotics, oral glucocorticoids may shorten the time to symptom resolution or improvement, although the benefits are small. And unlike topical glucocorticoids, systemic glucocorticoids pose a potential risk for side effects that outweighs the clinical benefits. I'm going to pause right there and I'm going to talk about what those are because I don't think doctors fully appreciate the risks. The risks of methylprednisolone, which is the Medrol Dosepak, and prednisone, which is another option you could give, are severe. Prednisone is potentially the most harmful drug you can prescribe. This is not candy. Prednisone causes at least 150 side effects, and some of them are horrific. Your patients are suffering dramatically because of this treatment. This is not a placebo. This is not something that you're giving to someone and it's like, oh, they're going to feel better. According to this, for sinusitis and so many other conditions, the benefit does not outweigh the risks. The risks include incredibly disabling psychotic and mental illnesses. Previously healthy mentally people will have disabling panic attacks, anxiety, psychosis, horrible insomnia where they can't sleep. And does it make any sense to give your person who needs sleep to recover from their infectious disease a drug that's going to stop them from sleeping? No, it doesn't. So please do not give this to someone. Other things. It can cause weight gain. It can cause moon face. It can cause osteoporosis, broken bones. People think, oh, that's not going to happen for a long time. No. Studies show that within the first 30 days of treatment, the risk for sepsis and fractures is very high. And it actually is highest in the first 30 days, and it continues over time. And so don't think that, oh, it's only 6 days of treatment. It's not going to do anything bad. It does. People are suffering. They call me and tell me all the time all of the horrible things that they're going through because, oh, well, I have a cough, so my doctor gave this to me. It's not helping. Please don't give it to them. Okay, here's another one, otitis media, an ear infection. So I'm currently suffering from hearing loss right here. I'm not sure if it's otitis media or otitis media with effusion or eustachian tube dysfunction. So I get it. Your patients are suffering and they're thinking, oh, it's just swelling and inflammation and anti-inflammatory would help. But no. According to UpToDate, the use of systemic glucocorticoids has not shown to be beneficial for the management of chronic eustachian tube dysfunction or OME. In the absence of evidence for benefit and given the risks of adverse effects, we agree with the 2016 clinical practice, which would recommend against the use of systemic or nasal glucocorticoids for the treatment of middle ear effusion in children. So it doesn't help with otitis media either. So what are the exceptions? What are the only reasons somebody should be given this when they're coughing, when they have some sort of infection, when they're having cold, flu, whatever? The only people who have a benefit that outweighs the risk. And as I mentioned at the very beginning, For influenza, it's actually worsening their risk for death. So the only people who will benefit from a Medrol Dosepak are those who actually have asthma or COPD, period. I cannot find any evidence that any other diagnosis can benefit, that the benefit is greater than the risks. And so, according to the GINA guidelines, it says, as a last resort, add on low-dose oral corticosteroids less than or equal to 7.5 milligrams a day, which is not this, by the way. This is not less than 7.5 milligrams. May be considered for some adults with severe asthma, but maintenance oral corticosteroids is often associated with substantial cumulative side effects. It should only be considered in adults with poor symptom control and or frequent exacerbations despite good inhaler technique. A lot of people are terrible at using their inhalers, so you should watch them do it. And adherence with step 5 treatment. And after exclusion of other contributory factors and trial of other add-on treatments, including biologics, were available and affordable. Patients should be counseled about side effects. Please counsel them about side effects. Please tell them this will probably make it hard for you to sleep. This may cause anxiety or make you feel jittery or have so much energy like you want to go like clean your whole house. This is going to make you hungry. This might help your cough, but we don't actually know for sure. Tell them that. Tell them that there's a really good chance they will have side effects, that the number needed to treat to have side effects is like 1. The number needed number needed to harm is 1. The number needed to treat to have benefit is like 15 or 16. So like, I don't see that that's helpful, right? 70% of people who take prednisone gain weight. That's just one of the 150 side effects. People are harmed by these medications. And then COPD. So if somebody has community-acquired pneumonia and COPD, up to date says this. In these circumstances, the use of glucocorticoids is for the treatment of the acute exacerbation of COPD, not for the treatment of community-acquired pneumonia. There is basically no one with community-acquired pneumonia who needs treatment because they're not actually getting it for community-acquired pneumonia. They're getting it for COPD or for asthma, not pneumonia, not COVID, not flu, not sinusitis, not ear infections, nothing. Nobody needs this. Nobody. Please stop prescribing it. Signing off is Dr. Megan, the prednisone pharmacist. I'm a board-certified doctor of pharmacy. You can find me at prednisonepharmacist.com. Thanks. Signing off is Dr. Megan.